In the late 1800s, G.V. Black perfected what became the accepted formula for dental amalgam. That formula is still in use today. There are two camps on the use of dental amalgam. One says amalgam is unsafe and should be banned. The other says it is safe and effective. There is also a third camp. Amalgams just don't work very well in promoting good long-term oral health. According to Delta Dental, there are more than 100 million amalgam restorations placed each year in the U.S. So let's look at some numbers from a national view. Using representative costs for the least expensive type of restoration, combined with Delta Dental's assertion of 100 million amalgams annually, we're spending $15.5 billion annually on such restorations. Using biomimetic techniques, this would increase to $25 billion. Why would we do this? The reason is that about 80% of the dental procedures in any given practice are based on the recurrent problems that developed within a previous restoration. Amalgams expand, leak, crack teeth, and provide pathways for future, more extensive and expensive dental decay. Biomimetic restorations can reduce most of this. However, while biomimetic restorations can almost eliminate this number, they can and do occasionally fail. As far as healthy tooth structure, they fail safely, but just to be conservative, we'll reduce our rate of 80% to 70% in our calculated numbers. If we were to reduce the number of re-restorations by 70%, we would reduce the annual number of restorations from 100 million amalgam restorations to 30 million biomimetic restorations. Restored biomimetically, even with the associated additional costs, that's still an end-state savings of $8 billion. Further, dentists who perform biomimetic dentistry report a reduction in root canal therapy by 75% in those patients treated with biomimetic techniques. While the numbers may vary, according to the American Association of Endodontists, there are 15 million root canals performed in the U.S. each year. There are varying price points for these procedures, so we will use the least expensive realistic number in our calculations. If we were to reduce the number of root canals by 75%, it would provide an end-state savings of over $5.5 billion annually. We see here that the combined savings make for costs for both type of procedures, both fillings and root canals, less than what we were initially spending for fillings alone. Moreover, root canal therapy is the precursor to crowns, extractions, bridges, and implants. If root canal therapy is reduced by 75%, how then does a 75% reduction in these procedures play out? Annually, there are some 29.5 million crowns, 30 million extractions, 9.4 million bridges, and while the number of implants done annually was not found, the market is estimated to be between $979 million and $4.2 billion. If we apply these numbers to appropriate dollar values for each procedure, you can see that we can reduce a cost of over $55 billion by 68%. Further, the cost of all of these procedures now becomes lower than what we were originally paying for fillings and root canals alone. That's a lot of savings. But that's a national view. Where does one begin so that this becomes actionable? A good example of a local view would be the state of Utah. Utah has a population of 2.8 million people in 29 counties. 75% of them live in these 4 counties of the Wasatch Front, and half of them live in Salt Lake County. The benefit here is that we have a statistically significant population in a small geographic footprint. That makes for an actionable universe. Utah's population is 0.91% of the U.S. population. If we reduce the representative costs for our basic restorations to that reflecting Utah's market, and then reduce the 100 million annual restorations by Utah's 0.91% of the U.S. population, we come up with costs of almost $52 million and an annual savings of $45.5 million, just for fillings. Likewise, considering a reduction in root canals, we have an additional savings of $51 million. Factoring in the reduction of our other procedures, we see a total savings of 69%. Like before, our cost for fillings and root canals is lower than what just fillings were before, and our cost for all these procedures is less than what we were spending on fillings and root canals alone. That's a lot of savings. So how do we act on this? The law of supply and demand suggests that if Utah has 0.91% of the population, it also has 0.91% of the dentists. That's about 1,550 dentists, and they could all be trained in about 5 years. In 5 years, some dentists will retire, but there will be an equivalent influx in newly graduated dental students, many likely biomimically trained. This is an actionable number. Our reduction in re-restorations against the status quo is calculated for an end state of 7 years in order for the training to take hold and work its way down to patient treatments over time. That suggests that the break-even point for our savings comes out to about 3.5 years. Utah's overall cost within this 7-year endpoint decreases in this fashion as well, with a break-even point of just over 5 years. And just as a sanity check, these savings are calculated against the least expensive procedure costs we could use. Not all restorations are single surface, and not all root canals cost $500. In the long run, the overall savings will be significantly higher. So, are these numbers viable? Are they acceptable for pursuing a more scientific economic study? The assertions we present are as follows. While initially more expensive, biomimetic restorations reduce long-term costs by more than 70%, which leads to a 75% reduction in the need for root canals, and as a function of that, an additional 75% reduction in crowns, extractions, bridges, and implants. Working in small markets makes for an actionable plan, allowing these treatment modalities to gain a foothold and for the benefits to be realized. But in order for this to happen, the ADA must define appropriate treatment codes in their CDT. CDT stands for Common Dental Terminology, or formally, the Code on Dental Procedures and Nomenclature. CDT codes both dictate and restrict what procedures can be described and submitted. The CDT is owned by the ADA and was named as a HIPAA standard code set in 2000. It is therefore the standard used by dental plan providers such as these. Available coding facilitates successful metrics, but if dentists can't precisely document the biomimetic procedures they're performing, then we have no way of accurately measuring its success. Appropriate CDT codes are an absolute requirement. It costs almost nothing, but provides a sound framework for measuring success so that next steps can be intelligently and confidently addressed. The numbers suggest further study. As an aside, you can find online a study from the Public Health Service. Its topic is dental amalgam. A central theme in its conclusions was the preservation of natural tooth structure, as opposed to what is called the amputational processes used with the conventional use of dental amalgam. They ended with a reminder that it is important for the dental profession to keep informed of developments in dental materials. This is significant, in that this report was written in 1993. There have been 20 years of research and clinical experience since this report, all of which support biomimetic techniques. It's time to take some action, and starting in micromarkets facilitates this action. Aside from the significant oral health benefits biomimetic dentistry offers, the financials speak for themselves. We can reduce the price of healthcare tomorrow by spending a little more today. Lifetime oral health care costs go down, helping patients, business, and the economy. Dental plan providers save money, premiums per participant go down as a function of savings, patient co-payments go down as a function of less need for expensive, invasive procedures, and as a function of such reduced and avoided costs, dental coverage should then become available to more people. And we haven't even addressed the link between oral health and systemic health. This is just one micro market. Are there others? There probably are. Rhode Island, Delaware, and Washington, D.C. all present similar opportunities in terms of population and geography. Likewise, Long Island. It has the same population as Utah and is only 1/3 the land area of the Wasatch Front. With appropriate commitment and additional training facilities, these similar markets could be addressed in similar timeframes. And with success documented in micromarkets, we can create a model for additional markets and subsequent national adoption. So, if this arithmetic view of the numbers points to a greater truth, then there are some necessary next steps. Validate the economics with an actuarial analysis, embrace the paradigm, and motivate key organizations to adopt the necessary processes. We can replace what has become the traditional dental cycle. This will reduce costs, improve health, and increase access to care.